Hello? Hello? Good evening. How are you?
I'm
Good?
Good, how are you?
Good. I'm good. Thank you. So, today is one of those lengthy days. You received an email from Virtua. Uh, it contains all the information and paperwork and documents that you need to perform and prepare for entering the hospitals. It's a lengthy list. Uh, my first request is if you send any email to Virtua and send anything, any document to Virtua, please copy me in your emails so I can have the track of your communication. If there is any problem and I have to follow it up, I have the track of your communications, okay? Second, you don't need to prepare all the things on that list. Some of those items must be prepared by me or the university, okay? So have a look at those documents and specifically focus on the lab tests and vaccinations and the medical aspects, okay? The rest of the documents, I will check with the university. And if there is anything necessary that you must prepare, I will let you know. Okay? So don't focus on the preparing documents, for example, background check or um, any letter. Um, uh, just for now, focus on the medical aspects, the vaccinations and other things. I hope everything goes well. Um, so let's move on to our screen poll. Um, in the seminar discussions, today, as I told you last week, I want to discuss about emerging topics in imaging in orthopedic surgery. We discussed the basic concepts in imaging for CT scan, MRI, radionuclides, ultrasound, and X-ray. What we discussed was what we currently have in practice in medicine. But today, I want to discuss some future technologies and the technologies that are emerging. They are not in current use, they are under investigation, and some surgeons use them, some surgeons are not familiar with them. And those surgeons who use them, they are using them on a research basis, not on a clinical basis, because they have not been proven in clinical use yet, but they are the future of imaging. And good news for you, we have several lecturers for these seminars, which start at the beginning of October. We have a trauma surgeon who will discuss the emerging topics in trauma for you. We have a hand surgeon, elbow surgeon, shoulder surgeon, knee surgeon, sport medicine surgeon, and they will discuss the emerging topics in their specialties. And the good thing is those whatever I discussed based on the technology. They will discuss based on the clinical applications, and it will be a little bit different. So their presence starts on October 3rd, and I hope we will continue with them. And also we have some engineers that will have lectures for you. So you became familiar on Tuesday with the imaging. I'm not going to discuss anything that I have discussed before. The first emerging topic is functional MRI. We discussed the MRI and we saw that MRI gives us an anatomy and a structure. But sometimes we can use the MRI to track some molecules. And based on the function of that organ, we can detect that molecule. And if the amount of molecule is higher than normal, it means that organ is functioning more than usual or is not functioning. So based on the amount of that molecule that we detect, we can analyze the function, not anatomy. Currently, functional MRI is in clinical practice and it is being used in clinics for some brain diseases. They have found some connection between some parts of the brain and some diseases in the brain, and they can track that disease, and also they can track the course of treatment with functional MRI. They have been able to use the functional MRI in orthopedics for some problems that are associated with the brain, like some chronic pain syndrome, some post-surgical problems, or some neurological deficits that causes some orthopedic problems. But they are still under investigation. And also, they are investigating the use of functional MRI for other organs. They are working on finding the similar molecules that they have found in brain. By similar, I mean functionally similar, that are unique to other organs like heart or bone or cartilage. And based on that, they can find the function in these organs, but it is still under investigation and they haven't found anything yet. Sorry. There are some other new technologies in MRI. One of them is diffusion tensor imaging. Diffusion tensor imaging actually maps the amount of water molecules in the tissues. This is a classic MRI image, which gives you the anatomy of the different organs: cerebellum, cerebrum, brainstem, and different parts of the head. And as you see, this is a classic MRI image. But with DTI, diffusion tensor imaging, they can detect the pattern of diffusion of water in the tissues. And we know that musculoskeletal system, not muscular part, the skeletal system is a connective tissue, and it contains a ground substance, and the ground substance contains lots of water. So, but by studying the pattern of diffusion of water in these in the ligaments, in bone, in cartilage, we can define the injuries in these tissues. And with this technique, we can find the injuries more accurately, and we can find the microscopic injuries, and it is a revolution in MRI. Another advanced technique is something called elastography, magnetic resonance elastography, or MRE. In elastography, actually, we apply pressure to the organ that we want to study, and then we detect the reaction of this organ to this applied pressure. First, we have an imaging without the pressure, and then we apply the pressure and have another imaging. There are normal patterns for normal tissues. If we have a pattern that is away from the normal pattern, it means that we have an abnormality there. This abnormality means the amount of cells or fibers may have changed. There may be a tumor, there may be an injury. So this technique is very limited, has been used in some soft tissue diseases like liver, or in other abdominal organs, but we are hopeful that we can use them for ligaments and muscle injuries. And it can give us any abnormalities, not only injuries, abnormalities, tumor or degeneration in the muscles and cartilage and ligaments. And it can help us with their diagnosis. So there are three techniques that are evolving in MRI. Besides that, we have new MRIs with more powerful magnets. I told you in clinical use, the magnet is between 0.5 to 3 Teslas, but higher power magnets are also available now for research because they are very expensive. But as the technology develops, they become less expensive, and the clinician can have access to them because the insurance must cover their expenses, and that is a problem. But for example, 10 years ago, if you ask a physician about 3 Tesla MRI, it was something that would never happen, but now it is in practice. And I am sure in future, 5 or 7 Tesla MRIs will be available to all clinics and it can be in use. In ultrasound, there are also some advancements. One of them is using high frequency ultrasound to increase, by increasing the frequency of ultrasound waves, we increase the resolution. So we can see the detailed structure of organs. And it will help us a lot. You may say why it is not, it is something very easy to produce, but why it is not in clinical use? Because when we increase the frequency of ultrasound waves, the reflection and absorption of these waves increases. So they cannot penetrate the tissues perfectly. So when we increase the frequency, we need to use this technique for superficial tissues, like tendons or ligaments that are under the skin and they are not deep. If we want to check the deep organs, we cannot use high frequency ultrasound. So since most of the tendons, muscles, and ligaments are under the skin and they are not deep, we can use them, especially in sport medicine. We can use it for accurately diagnosing the injuries and following up the treatment course. The same as elastography with MRI, MRE, we can perform the elastography with ultrasound. And here we don't need any extra device to apply the pressure because the probe can work as a device to apply the pressure, and we can easily apply the pressure to the tissues and see the reaction of the tissue to the pressure. And in this way, we can check the stiffness of the tissues. If the stiffness is normal, we have a pattern of normal, so we can, it is a normal tissue. But if the pattern of stiffness is not normal, it means there is something wrong. Ultrasound cannot make a definitive diagnosis for us, but it shows us that there is something wrong. And when you have a trauma to a ligament and you have a abnormal pattern of stiffness in that ligament on ultrasound, it means that there is an injury. Again, elastography increases the accuracy of diagnosis, and it can also help us for monitoring. You remember for X-ray, CT scan, and fluoroscopy, we discussed contrast agents. For ultrasounds, also I said some contrast agents. Recently, something very interesting has been developed, and that is they have called it contrast enhanced ultrasound, but actually we use contrast for ultrasound by injecting some air into the tissues, but that air was very invasive. But the recent technology was developing some micro bubbles in a fluid that contains very tiny amount of air And this air is not, it is an inert gas, not air. This gas is very tiny and in the form of microbubbles inside the fluid. And we inject that fluid into the vein near the area that we want to evaluate. And that microbubbles pass through that organ that we want to evaluate and create a contrast for us, because uh, air is hypoechogenic, so it produces a dark area for us. And it shows that in this area, we have a hypervascularity because lots of air bubbles has been accumulated here. In a normal, in a conventional ultrasound, we don't see anything here abnormal. It is a tumor, but we don't see anything in the center. But with this contrast enhanced ultrasound with microbubbles, this area has lots of microbubbles accumulated in it. It shows that the vascularity here is high. And in this way, we can make diagnosis. These microbubbles are harmless and they can pop and dissolve in the blood, and they will be excreted through lungs. Another technology that is gaining interest is VR and AR. I'm sure you are familiar with the difference between VR and AR. For surgeries, we use VR for education, as we want to use it for our course, and also for preoperative planning. So before the surgeries, the surgeon can use VR to practice the surgery, to practice the steps, and to check the landmarks, to learn the different steps and landmarks about the surgery, and also can perform the preoperative planning. But we cannot use VR for during the surgery because the VR blocks the view of the surgeon and the surgeon cannot see the surgery. So we have to use AR, augmented reality, and project the reconstructed view of something on the surgical field. Many technologies are being used and many ways are being used to use AR during the surgery. One of them that is really game-changing is the preoperative planning that you have performed. You have designed the location of cuts, location of the implants, location of the plate, everything you have designed on the computer. So during the surgery, since the information came from the same patient, because you extract the information from the CT scan of that patient, the projection that you project over the surgical field, as you see here, this is exactly the same, it has the same anatomy of the patient because it came from the same patient. So when you project your preoperative planning over the surgical field, you can determine accurately where to cut, where to put the implant, where to put the plate. So everything will be, you can see what you are doing, if you are doing it correctly. And if you are not doing correctly, you can correct it. But there is a huge problem with augmented reality technology for surgery. And that's its device. The current augmented reality devices provide two problems for surgeons. The first, except as far as I know, except for one company, all the AR devices have a semi-clear vision field. The goggles they use cannot be clear, because if they are clear, you see through it. I mean clear, I mean totally clear, like a glass. You see through it, and augmented reality view will be impaired. So you may have seen the most advanced one is Vision Pro for Apple, or HoloLens for Microsoft. And when you wear them, actually, it is something like wearing a sunglass. So for a surgeon, wearing a sunglass during surgery makes the surgical field less visible. So this is one problem. The second problem is their weight. They are heavy, and the surgeon cannot wear them through the surgery from the beginning to the end. Personally, I use HoloLens for surgery, and after 15 minutes, I had to ask somebody to remove it, because my nose bridge became so painful that I couldn't tolerate it, and I couldn't concentrate on surgery. So I had to remove it. They are working on making it less and less heavy, but they are still heavy. The new Microsoft HoloLens is much lighter, but still it is too heavy to wear it during the surgery. But as a temporary measure, for example, if the surgeon wants to use it during the cut, and then remove it, and during the next cut, wear it, and then again remove it, if the surgeon agrees to do that, they are perfect. But it adds to the time of the surgery, and sometimes the surgeons don't like it. And believe me, the only thing that is an obstacle to daily use of augmented reality devices in surgeries is their weight. If the weight is becomes so light that the surgeon can wear the headset during the surgery, during a lengthy surgery, without feeling any pain or tiredness, they are perfect technologies that can help the surgeons greatly. Tuesday, we discussed the different CT scan technologies. And you remember, in all the technologies, we may have different detectors, even a large number of rows of detectors, but in all of them, we had one X-ray tube. But in dual energy CT scan, which is a new technology, they are using two X-ray tube, two X-ray source. And with these two X-rays, they can differentiate between different tissues. Between these two CT scans, the lower one is dual energy, the upper one is the conventional one. The anatomy is the same. Dual energy doesn't show anything more than the conventional, but it can differentiate between different tissues. So here, it can show you that this is a calcification, but here you cannot be sure that it is a calcification. Only this part below my pointer is calcification based on this CT scan. But here it can show you that the calcification extends up to here, and it can differentiate between different tissues. But dual X-ray means 2 times X-ray exposure, and it is not acceptable. You also remember that let me go back here. You see the X-ray source radiates the X-ray like a triangle in a diverging pattern like this. These are fan beam CT scans, and all the CT scans currently are fan beam. So they scan the whole body, a large area, because we need to gather the information for every part of the body. And the reconstruction performed on this information produces the information for all the body that was scanned. For example, all the chest, all the abdomen, all the head. Sometimes we don't need that. A new method for CT scan called cone beam CT scan has been produced. The X-ray source sends the X-ray like a cone, which is much more limited instead of the fan beam. And it can perform the the imaging on a localized area. For example, consider the head of the patient. If you perform this conventional CT scan on this head, at the end of the CT scan, you have the information about all the structures in the head. But you only wanted to study the 3 or 4 teeth in the upper jaw. But you have the information about every part of the head to study that small area. With cone beam CT scan, you can focus on that small area and ignore the rest. So the amount of X-ray exposure is less, and the resolution will be higher for that area. We don't need anything to know about the ear or the neck and the lower jaw of this patient. We only need to know about this area in the upper jaw. In orthopedic surgery, especially about the upper limb, when you want to perform the CT scan of the upper limb is attached to the body, and you cannot send the upper limb alone in the CT scan device. It must be beside the patient, and the patient with the upper limbs must go into the gantry. And when you perform the CT scan to study a small bone in the wrist, actually you are exposing the whole body of the patient to X-ray, and it is not necessary. And at the end, you have the information about because when you put your hands beside your body, your wrist will be beside your pelvis. So, or you can put the hand of the patient above the chest. So wherever you put it, if you put it beside the pelvis, you have the information about the pelvis because you expose the pelvis, but you want only to study the small bone in the wrist, and you have studied the whole pelvis. Or when you put it on the chest, you have this bone in your final CT scan, but you have the whole chest below it, and it is not necessary. So with this cone beam CT scan, which is not in current use, but I hope in near future, all the hospitals gain access to this. Many limited studies will be possible without exposing the rest of the body. We have, in conventional CT scans, we have two-dimensional reconstruction. CT scan itself is in transverse or axial section, but we can reconstruct it into other dimensional projections in sagittal and coronal sections. And we can reconstruct it into three-dimensional, you saw yesterday. But we have something called four-dimensional CT scan. And it is a three-dimensional CT scan, a conventional CT scan with three-dimensional reconstruction with adding time to it. We perform CT scan at different times. For example, we want to see the chest expansion during breathing. So when the patient inhales, we perform a CT scan, and then patient starts to exhale, and we perform another one. And at the end of expiration, the third CT scan. And the difference between these three shows us the amount of expansion of the chest during breathing. We can perform the same thing for seeing if a fracture is fixed or if there is any motion in the fracture site or there is any motion between the implant and the bone. We ask the patient, we put a pressure on the implant or on the fracture site and take a CT scan, and then remove the pressure and take another CT scan and apply the pressure in another direction and take another CT scan and compare these three CT scans with each other to see if there is any movement between the bone and implant or at the fracture site. This is called a four-dimensional CT scan. Actually, the fourth dimension is time, and we are adding fourth dimension to CT scan. But generally, when you tell people that it is four-dimensional, they are looking for something different in appearance. But no, it is the same with adding time frame to the CT scan. And another new advancement in medicine is using the conventional optical imaging, the imaging with the cameras. In itself, it is not useful. It doesn't add anything that we cannot to what we can see with our eyes. But sometimes we can use some techniques by adding something injected into the veins and then study the light emission or emission of a specific wavelength based on the material we injected. And then we can find the pattern of vessels in the tissues below the skin. This is one simple technique for studying the superficial tumors. Again, since the muscles, tendons, and bones are superficial, it can be useful in orthopedic surgery. It can study the vascular pattern, and based on this vascular pattern, since we know the normal vascular pattern, we can define the abnormal. And if we find any abnormal vascular pattern, it means there is something wrong. It can be a tumor, it can be an injury, it can be an abnormal vascular growth. So we can use this technique for some diagnosis. And the last advancement is the current computer science magic. artificial intelligence and machine learning. Like any other field in medicine and in orthopedic surgery and in imaging, AI and machine learning are being used for different purposes. And again, like many other fields, they are still in research and they haven't reached a clinical application. We can use them for different purposes. We can teach them for analyzing the images for us, and people are working on it, but up to now, not now, up to maybe 1 month ago that I checked it, there are no platform, no software, no AI that can interpret the imaging correctly. They can interpret it, but they can interpret only a specific aspect. For example, you can teach them to find the specific bone tumor in the in CT scan. If there is any other abnormality, it cannot find it, and you don't like it, because when we look at the CT scan, we find any abnormality, not only a specific time of bone tumor. So their use are very limited, but they are working on it. If they work, they can help us for diagnosing different abnormalities at the earliest stages. Also, we can teach the system with the information we have from previous patients. And based on this data, since the number of patients are large, it is a big data sample. So the machine can learn based on the previous information, can learn to predict the course of the current and future patients. And in this way, we can, based on this prediction, we can change the treatment to correct that course, but still in research phase. And the last one is image-guided surgery. One of them is we discussed about augmented reality. Actually, we can add AI to that, but still it is in research phase, and based on the information we provide to AI and based on machine learning for learning the patterns of the X-ray and MRI and CT scans, the AI can help us with designing the surgery and designing and preoperative planning and performing the surgery. But these are huge hopes for future. They haven't happened yet. Maybe they happened during one surgery and they helped with one surgery, but it doesn't mean they can be used conveniently for any surgery. They help with one, they may not help with the other. So, but we are optimistic that it can happen. Any question? No? So let's have a few, let's have 10 minutes. No, 10, not 10 minutes. I will close this Zoom, this meeting, and we will return at 5:50, okay? With the next link. That's okay with you? Okay. 5:50, see you on the next link. Bye.